This is Jennifer. I'm recording my week 3 blog. I scored pretty equally in the leadership skills quiz, 23 points in the administrative skills, 22 in interpersonal, and 25 in conceptual. I think that these attributes have been developed over the past 11 years by moving to various units and care environments and would help me to be an effective leader. In my current role, I serve as a charge nurse for my unit. The next step up for me in leadership would be to become an assistant unit manager. I would use my skill set to succeed in this position by working with staff to implement policies, help staff develop skills to succeed and advance their own careers, assure that there is an adequate skill mix among the staff that is present for each shift, and to provide care for the patients that are present on the unit. Sometimes I feel like, especially if units have grown in the number of beds that they have available, if there's a large number of new nurses that are on staff, sometimes that's one thing that is missed by management when they set the schedule for who will be there from shift to shift. It's very unnerving to look down the hall and realize that everyone that you're working with has not only worked on the specific unit for less than 6 months, but they've also been a nurse for less than 6 months. So I would try to curtail that in my next position, and to also uphold the goals of the organization. The facility where I currently work is in the process of a lot of change. One thing that we have been told over and over and over again is that we are trying to focus more on being a transparent facility, meaning that we aren't going to hide anything from anyone. Most of all, not everyone that works within the organization. So anything that's discussed in a meeting is turned out immediately to the staff entirely and honestly. So that's been a very big change for us recently. During this big process of change, we've worked with a variety of organizational structures and care models in order to trial and error what works best for us. And I think that what we have determined works best for us is to keep a large variety available, because not everybody likes to work the same way. When I first started working at the hospital that I work at now, it's a very large teaching facility. We had a very extensive vertical structure. It's a 4 million square unit hospital, so 4 million square foot hospital, so we have lots of different units, and so each unit pretty much had their own medical director, they had their own unit manager, they had their own assistant unit manager. And lately our hospital has focused on what our book calls flattening out, and we've been moving to a more horizontal structure with one medical director, one director of nursing, and one unit manager for each division within the hospital. So where I work, we have one medical director for all of oncology, we have one nurse manager for basic med-surg oncology, and one assistant nurse manager for basic oncology. And we have one medical director for the bone marrow transplant unit, and that also follows suit with one nurse manager and one assistant unit manager for the bone marrow transplant unit, which has been a big change for our facility. And then throughout the rest of the hospital, just depending on the size of the unit, some of the managers are picking up and taking care of 1 to 3 units full of nurses and patients. Again, just depending on the number of beds that are on that unit and the number of staff members that are employed by those units. My facility also has some elements of a matrix structure. We have a falls committee, for instance. We also have a chemotherapy committee, and we bring together different people from different departments to discuss errors that we have had, or potentials for errors that we have had. And so pretty much the goal of all the matrix portions of our structure are geared more towards patient safety. The article that I read was called Interdisciplinary Communication in General Medical and Surgical Wards Using 2 Different Models of Nursing Care. It was an article that was actually written in Australia, and it compared 2 different nursing models within 2 units that were pretty much the same there within one hospital. It focused on shared care in nursing, which is a multifaceted approach involving teamwork, leadership, and professional development, and the patient allocation model, which uses one nurse that's responsible for the care for a discrete group of patients, and it's an all RN workforce in the patient allocation model. It looked at the differences in interdisciplinary communication within the two different nursing care models, and what they ultimately found was that both models of care could be effective if it were supported appropriately by management and by the staff, and that there are several different models of nursing care that are effective at harboring an environment of interdisciplinary communication. It just really depends on staff support, the type of unit that is utilizing it, and the skill level of the staff that's present to utilize that structure. My organization uses several models of care. Many different units are again trialing and erroring different models to see what works best for their staff and their patient population. Most of the general units use a team nursing approach, RNs and CNAs and that sort of thing, all working together with a small patient group that's assigned to them for the shift. And then most of the critical care units use a total patient care approach, which would be one RN focusing in on the care of 1, 2, or 3 patients, just depending on the patient mix, and no CNAs. I have worked in various care environments, inpatient, outpatient, home health, that sort of thing. So I've been exposed to various models of care, and for me it really just depends on the type of place that I'm working and what works best. I would say for just general med-surg, unit-based sort of things, I prefer the team approach, and for critical care environments I do prefer that total patient care approach. Two things that my facility does to harbor the use of interdisciplinary models is that we do an interdisciplinary rounds on our patients every day. That includes the attending for the patient's assigned resident, their case manager, the pharmacist, the charge nurse, and if the bedside nurse is available to make it to rounds, they also come too. And that has allowed for greater communication between the patient and all members of their care team, and it lets us all share about the patient's condition and the goals for the patient care. And then the other thing that my facility does is we have a daily staff meeting where one representative from every unit in the hospital and every department attends. So that includes all the nursing units, physical therapy, recreational therapy, lab, dietary, executives, patient logistics. Everybody comes to the meeting, and their voice is heard. All the safety occurrences from the previous day are discussed. That could include things like falls, medical errors, medication errors, long patient wait times, anything that was an error or that there was a patient or a family member complaint about is discussed in that meeting. And so it sets into motion an immediate plan of action to correct problems, and then a follow-up is done on it the next day in the next safety meeting. And as a result, our facility has had a major decline in patient safety events. CLABSIs, CAUTIs, things like that have gone down exponentially. This is a good unit.